My name is Paul Feuerstadt. I'm a gastroenterologist. I'm here at GI Reconnect in Denver, Colorado. I'm here with my colleagues, Dr. Daryl Pardee, Dr. Sahil Khanna. I am an associate clinical professor of medicine at the Yale School of Medicine, attending gastroenterologist at the PAC Gastroenterology Center, and we're going to be talking about C. difficile this morning. Why don't I have my colleagues introduce themselves? Daryl?
Hi, I'm Daryl Pardee, professor of medicine and chair of the Division of Gastroenterology and Hepatology at Mayo Clinic in Rochester.
I'm Sahil Khanna, professor of medicine, again in the Division of Gastroenterology and Hepatology at Mayo Clinic in Rochester. Thanks
Awesome.
for having us, Paul.
This is great. I'm looking forward to discussing with you guys. So, look, there's been some changes with C. difficile that we've seen recently. We're going to touch on some of those changes this morning. I want to first talk about the epidemiology, though. We don't really have any recent definitive data on the epidemiology. So why don't we talk about your individual experiences with shifts in the epidemiology? You're seeing more C. diff, you're seeing less C. difficile, and contextualize your practice with sort of the broader picture. Sahil, why don't you go ahead?
There's two parts of the epidemiology when I think about it. It's the initial infections and the recurrent infections. Within initial infections, I think the hospital-acquired amount of C. diff that we're seeing has plateaued, if not gone down just a little bit. Similarly, for community-acquired C. diff, it's plateaued a little bit too. What I'm noticing different from recent times is that the amount of recurrences that were happening back in the day are probably going down just with using different antibiotics. The referral practices for C. difficile have also changed. We're seeing more and more C. difficile being managed in the community. That was not happening in the past. So few changes. None of this has been published or it has granular data behind it. This is kind of just my experience, what I've noticed.
Excellent. And Daryl, what do you think?
Right. So we have a C. difficile clinic, which is a referral practice, typically for multiply recurrent C. diff. And we're seeing less referrals for that. In the hospital, similarly, we see less infections. I think the results of intentional infection control practices, which is rewarding to see. And I think the referral pattern change, we've been discussing whether that reflects a true change in the epidemiology or just that primary care doctors and other specialists in the community are comfortable using some of the newer drugs.
Yeah, so I think I'm seeing similar things. Perhaps maybe the overall incidence is also decreasing a little bit, but certainly multiply recurrent C. diff, at least in my experience, has been decreasing a bunch. And I think it's probably as a result of some of the efforts that we've been making over the last decade and a half to try to educate, discuss the disease, get providers more comfortable treating more aggressively up front, learning about things like fidaxomicin, the add-on therapies, and the like, and hopefully taking it a little bit out of our hands on the more simplistic and just sending us the more complicated cases. Now, one of the other things that I think is an important hot button topic is sort of the acronym alphabet soup that is diagnosis of C. difficile. And we've seen shifts recently in the diagnostic algorithm. Historically, PCR as a singular assay was the assay looking just for the genes that code for the toxin. So it detected colonizers and there were problems with that. What do you guys think about the changes and where do you see the diagnostic algorithm going? Daryl?
Yeah, so at a fundamental level, I think the issue with diagnostic testing is there's no perfect test.
Right.
And this takes us back to our basic classes in med school where we talk about pretest probability and test characteristics. So the problem with PCR is that it's very sensitive, and in the right patients, it's very specific. But when you use the test inappropriately, for example, in a patient with abdominal pain without diarrhea, then the positive predictive value goes down, and that presents a problem. So to try to get around that and to make the results of the testing paradigm more accurate, most places are shifting to a 2-stage or 3-stage testing algorithm where you'll do one test, and some places that's a toxin-based EIA first with GDH and toxin A or B or both. And then if those agree, you say that that's a true positive. If they disagree, it's adjudicated by a PCR. Other places like ours starts with a PCR. If that's positive, it's confirmed by a toxin EIA.
Excellent. So it sounds like you've kind of shifted what you're doing a little bit. Sahil, what do you think about that new change? How do you think that's going to change the dynamic of detection and the clinical context of it for providers?
One thing to keep in mind when we interpret all of this is that you're as strong as the weakest link in the chain that you're trying to interpret. And the weakest link in our chain, unfortunately, is the toxin assay, because toxin is a protein. You leave it on the shelf, it degrades, your sensitivity is low. So you have to keep that in mind. The second part of this is the best test is the one that's available to you by the lab. If there's a test that's not available, your lab doesn't do the toxin assay, you have to rely then on the PCR assay or what's available. I do think that providers have to interpret this in context. In the past, we were doing a lot of over-treatment, even colonizers. We have to be careful and see if you have a negative toxin, you're not under-treating and treating someone with a different drug that may lead to worse outcomes. So to be very cautious in how you interpret these tests.
Yeah, and I think that's really important. Daryl, you've been a big proponent, and I listened to your lectures on this, but essentially, we need to understand what's happening with the patient and what they're saying to us. So if a patient's not having 3 liquid bowel movements in a 24-hour period and not having sustained symptoms for a couple of days, that's a scenario where we shouldn't be sending off a PCR assay as a singular assay. And I think that had led to some of that overdiagnosis, some of that colonization, and treating that colonization, which is kind of funny to say, but if you give vancomycin to somebody who's colonized, you're more likely to actually cause C. difficile. And that's something that's a little bit challenging for people to think about, or providers to think about, who aren't quite as in the weeds on this topic as we are. So why don't we...
Can I emphasize that? Because I think that's a critically important point. People have to be very careful not to just rely on the test.
Yeah.
So someone with no pre-existing diarrheal disorder gets clindamycin for a dental infection, gets diarrhea. If the tests are discordant, we still have to think about that patient and say, if there's no other explanation, is it reasonable to give the person treatment for C. diff? On the other hand, someone with chronic diarrhea, no change, maybe more abdominal pain, we get a test for that patient. Then maybe the discordant test is telling us something completely different. So the tests, whether you combine them or use them singularly, don't get us off the hook from thinking.
No, and I agree with that. And one of the things that you both have heard me say this before, one of the reasons I really enjoy seeing patients with C. difficile is that very frequently they don't actually have C. difficile when they're sitting in my office, and I need to think through the case and figure out what they actually have. And I know your study group has put out some data looking at the other diagnoses that these patients have: the microscopic colitis, other inflammatory bowel disease, irritable bowel syndrome, et cetera. And you're right, it's about that thinking cap. And unfortunately, I think frequently some providers, due to time constraints, et cetera, don't necessarily have the time or feel pressured to not be able to actually take that history that's so important. So really, it's put our thinking caps on, and we can be productive and get to the right diagnosis for these patients and treat them properly. So we've been working for the last 15, 20 years at getting new treatments for C. difficile. And we've had some success. We've had fidaxomicin that came on board in 2011. We had bezlotuximab, which came on board in around 2017. Now, bezlotuximab, of course, is the fully humanized monoclonal antibody that's an infusion given during standard of care antimicrobial that had very nice data showing reduced rates of recurrence. But we found out, as a nice Christmas present, right before Christmas in 2024, that unfortunately bezlotuximab would no longer be available. And I think that that's a significant paradigm shift, because at least during the pandemic, I felt as though when fecal microbiota transplant was not as available, people became reliant on this. So what are your thoughts, Sahil, on where we're going to go with the loss of bezlotuximab, and how can we compensate for that?
Paul, I've learned from you more than anyone else is that treating C. diff is a two-pronged approach. You treat the active infection, do something to prevent the next one from coming back. And that's where bezlotuximab came into play. It was interesting that it also had a role in the very first infection, where you could combine that with an antibiotic in the right risk factor patient population and prevent that second infection from coming back with a sizable delta. That's gone away, and that's what bothers me the most. For the recurrent and the multiply recurrent infection, we've got so many other options, so I won't miss bezlotuximab in that situation, but I do miss that in my first infection patients with the risk factors.
Yeah. No, I think that's a really important point. The other area that I think about are the patients who are severely immune compromised. These are the patients that we can't really give fecal transplant to, or we shouldn't be giving them to, due to their immune suppression. And what do we do in that circumstance? So, Daryl, what do you think you would do? You have a patient who's severely immune compromised seeing you in the office. They're stable. Let's say they're on vancomycin, and you're worried that they're going to potentially recur in the future. What are you going to do as your approach there?
Right. So first, let's emphasize that microbiome-based products are not contraindicated in the absence of severe immunocompromise, like absolute neutropenia.
Yes.
And then several groups have published that on the safety of FMT in people who are otherwise moderately immunocompromised.
Correct. Yes.
But there are obviously patients that are severely immunocompromised, it's kind of fun to go back to history
Yes.
and say, what did we do before we had FMT? So if we can't use it, what did we do before we had it?
Yes.
And that was in the appropriate patient population that's at risk for recurrence, high risk for recurrence, then chronic suppressive vancomycin is reasonably effective and reasonably safe. And at low dose, typically once a day, even once every other day, reasonably affordable as well. Yeah. Now, in particular, if someone has an anticipated reversal of their immunocompromise, you can do that as a bridge until they become a better candidate for a microbiome replacement product.
Yeah, and that's frequently what I've been doing in my practice. If that situation presents itself, Sahil, do you have anything else or different that you might do in those patients who are severely immune compromised?
If I'm seeing them for the very first infection, I'd prefer to use a different drug than vancomycin. I'd prefer to use fidaxomicin,
Sure.
perhaps the extend regimen,
Yeah.
just reduce that risk of recurrence at the very first time. But when you get to recurrent or multiply recurrent, your hands are kind of tied. You know,
Right.
this person's going to get an antibiotic for another infection because of immunosuppression. They're going to got pneumonia, UTI, other things because of immunosuppression. So you're going to keep them on vancomycin.
That sounds very reasonable. And I think Daryl made a really important point, which is essentially that with mild to moderate, there's data that shows that that FMT or microbiota restoration therapy can and is safe, and the American Gastroenterological Association guidelines say as much, published in February of 2024. Now, there has also been another shift. Open Biome, the largest stool bank in the country, has sunset as well in terms of shipping product to, I'll say, practices and divisions throughout the country. And that was a service line that was stable from around 2013 until the end of 2024. Daryl, how do you think that's going to affect practice, clinical practice, and providers?
Well, luckily, and I think because of this fact, Open Biome stopped shipping product, we now have approved products that can fill that gap. We're fortunate at Mayo Clinic that we still have our own donor screening program, so we can do traditional FMT if we need to. Most places don't.
Right.
We can still do patient-directed donation where that family member or another loved one could donate. But that's unwieldy and not very practical. So really it shifts then to the FDA-approved products that are now available. And frankly, even though we have our own FMT program, more often than not, we're treating patients with one of the approved products. So that would be Voust, which is an oral product, or Rebiota, which is an enema-based product.
Yeah. And I think that the FDA-approved products have been a game changer for all of us in practice, and hopefully for all clinicians here in the United States, because it gives some validation to the safety and the efficacy of what was a little bit of a black box, although we all knew well before that it probably wasn't going to be, and we understood the safety and efficacy. Sahil, why don't you talk to us a little bit more about your experience with those products, the FDA-approved products?
Both those products went through about 10 years of rigorous clinical trials. They started around the same time, 2013, 2014. They both have had more than 4 or 5 clinical trials done, both blinded, double-blinded, randomized, open-label, expanded indications with inflammatory bowel disease patients, immunosuppressed mild to moderate patients. The first and most important point is safety, and we have not seen so far disease transmission, infection transmission, high-risk adverse events, mortalities from those products. Second aspect, of course, is efficacy. Both those products have shown efficacy against placebo, or when you compare them. Well, and I should say it's antibiotics followed by one of those products compared to antibiotics followed by placebo, and you see a delta, clinically significant, meaningful, and efficacy. And the third thing is the ease of prescription. I would think at this point, it's becoming easier and easier for people to prescribe it, insurance to approve it in the right clinical context.
Right. And I think that's a really important point. You know, you have 2 products. You have Voust, which is an oral product that requires a gentle bowel lavage the evening before. You have Rebiota, which is an enema formulation. And also you published some data recently looking at that being applied via colonoscopy, which is a little bit more of the old school approach, but showed excellent efficacy for that product also. I mean, there are some differences between the two of them. Voust is a bit of a narrower spectrum just for MICUD spores. Rebiota is a broader consortium, both spore and non-spore forming bacteria. At the end of the day, though, I think that it's important that we just communicate with patients about what the process is for this. So one is an in-office enema or a colonoscopy associated with rebiota. The other is something where you just give the standard of care antimicrobial. And then there's what we call a washout period, obviously, which is the time where patients receive nothing. That's where they actually pass the vancomycin or fidaxomicin from their body. With Faust, they will receive a gentle bowel lavage, magnesium citrate the night before, and then they'll take 4 capsules daily for 3 days. I think for me, in my practice, I just talk to the patients about what their preferences are. I talk to them about what the risks and benefits are. The risks, obviously, you discussed. The side effect profile really hasn't been very concerning for me, both within the pivotal trials and in clinical practice. Things like distension and fatigue, constipation, chills, diarrhea, these are all short-lived. So I don't think that it's something that patients or we need to be overly concerned about, or providers who've never used these products need to be overly concerned about. And I think that they fill a really important niche in minimizing the risk of recurrence for these patients at greatest risk. I think probably the biggest thing is, where does it fit into our practices? And I think each of us probably agree. The guidelines repeatedly say second recurrence and beyond. The most updated guidelines say for the prevention of recurrence, which opens the door for first recurrence. Where do you guys place this? I'll say second recurrence and beyond. My assumption is that that's standard. So where do you place this for your group with first recurrence? Is there a specific subset, Daryl, that you?
It's a spectrum.
Okay.
Someone that has had, say, a severe infection, they were in the ICU. I don't want that to come back. I'll give them a microbiome replacement product when I see them.
Yes.
Whether it's first infection or first recurrence, if I can get it approved. Mm-hmm. Young, healthy person, maybe they finished their fidaxomicin or vancomycin 5 weeks ago.
Right.
They're already on the downslope in terms of the risk curve. So then I may wait for this second recurrence.
Got it. That's fair enough. Zeal, any specific groups that you consider most frequently with first recurrence?
Couple specific groups. One is inflammatory bowel disease.
Okay.
Those patients are at a higher risk. It's risk stratification.
Yeah. Your
non-IBD patients, first recurrence, we think next time it's 40%. IBD is much higher. So we do in your inflammatory bowel disease patient. If somebody's other medical management has been on held because of recurrent C. diff, frequently chemotherapy gets held.
Right.
And they're like, my doctor is going to say, unless this is cleared, my cancer is not going to get treated.
Yes.
In that patient population, make sure they don't have neutropenia and other things lingering on from the recent most chemotherapy. That's another one that I think of in first recurrence.
Yeah, and like so many other things, I completely echo everything that you both said. So now, as we think about this, let's talk a little bit about fidaxomicin. Great drug, works really, really nicely, limited by cost historically, potentially coming off patent relatively soon. I personally think that's going to be a game changer. I think that if the cost comes down significantly, probably in my view, this will be something that'll become first line, even though the IDSA SHE recommended it as first line preferred over vancomycin. Zeal, any thoughts around where fidaxomicin might fit if and when it comes off patent?
I'm hoping it'll become first line, not only in the hands of ID and GI, but also in the hospital, in primary care, in urgent care. Although not on the label, I prefer what's called the extend regimen of fidaxomicin off the bat if I get to use it, which is the same number of pills. It's twice daily for 5 days, skip day 6, once every other day, day 7 through 25. The recurrence rates are much lower based on my experience, but also based on a clinical trial, which compared it to a standard vancomycin course.
Excellent. And Daryl, any thoughts on where fidaxomicin?
Right. So if cost wasn't an issue, it wasn't much of an issue, it would be the first line drug, just like the IDSA suggests in their guidelines. But we live in the real world where cost does matter. It
matters.
Especially to our patients, but to society as well. So we had a group at Mayo, GI, infectious disease, and pharmacy, and we looked at the literature and we decided that for patients with 2 or more risk factors for recurrence, including IBD, age, et cetera, that we thought the cost of Fidaxo was worth it for first infection.
Yeah.
For someone with 0 to 1 risk factors, we thought vancomycin's good enough. And we did a study of fidaxomicin use at Mayo Clinic. And what we showed was that for patients that had several recurrences before Fidaxo was used, with the thought that maybe increases the cost effectiveness, we actually saw a lowering of response and a significant increase of recurrence.
Yeah.
Because the microbiome's already been
Right. Depleted.
destroyed, so the benefit of Fidexo is lessened.
Yeah, and I think that's an important concept that you're alluding to, which is essentially Fidexo's benefit is that it has a narrow target, so it has less of an effect on the surrounding microbiota. Therefore, there's less regrowth that has to happen afterwards. But if a patient has cycled through a couple of treatments, then they're already burned out, and the benefit of fidaxomicin is less. And I really appreciate the Mayo approach and how you thought through that, because I think that's probably the most beneficial effect. And I think it gives us a nice roadmap for future,
Right.
which is essentially, if things are equal up front and they have 0 to 1 risk factor for recurrence, it's still reasonable to use vancomycin. But if costs are equal otherwise, fidaxomicin is definitely a reasonable choice there. So this was a really great conversation. Does anybody have anything else that they want to share?
Well, there's still a gap that I think has become more and more prominent with open biome sunsetting. What are we going to do with our fulminant intensive care patient who's not responding to medications and is not a surgical candidate? Because open biome had filled that gap, or conventional FMT had filled that gap.
Right.
I'm going to put that question to you and ask you, what would you do in that situation?
So for me in that situation in 2025, I consider the broad consortium of Rebiota probably the best answer. And within our healthcare system, we have used this using Monica Fisher's protocol, which is essentially every other day fecal transplants. To treat this until there's resolution of the pseudomembranes. And we had, it's an N of 1, so I'm not going to say much more than that, but we had a very, very nice response with that. I think nationally that's sort of been the trend. So what are your thoughts on that?
I agree that that's a highly mortal condition.
Yep.
Those patients are going to die if you don't do something. So we luckily have our FMT program. We've done FMT in maybe a dozen or 15 of patients with fulminant C. diff, not candidates for the operating room, and we've had probably a 60-70% response rate. So really impressive, better than I would have predicted. There's a meta-analysis showing response in the 60% range.
Yeah.
Adverse events in this very, very sick population were not terrible.
Yeah.
So it's to the point now where I ask my residents to consider us FMT while or before they call the surgeons to consider taking out the person's colon.
Well, that's a really strong statement. And I think along the same lines, I think it's a less of a severe process for the patient to go through, especially when they are as ill as they are with fulminant disease. And it seems to work. So I think it's anecdotal now or expert opinion now, but hopefully with time we'll gather some more data and be able to put together a case series that further validates the safety and efficacy. But when they're that sick, saying that there's minimal other adverse events is a very strong statement, right?
Great. And I think keep in mind that this is not on the label for Rebiota.
Yeah. Yes.
This is not on the label for Vows.
Vows,
I would not
yes.
use an oral because at this point people have ileus.
Correct.
The clinical question always is, do I deliver via an enema? Or do I take a camera up there, do a gentle flexing? Paul, you mentioned we're looking at pseudomembranes. It's probably a better idea to deliver that with a endoscopic approach or a colonoscopic or flexing approach. And we've seen that you can deliver the product.
Oh, agree completely.
Right, and usually not colonoscopy. They're so sick you don't want to do a bowel prep or try to get up to the proximal colon. But FlexSig has been reasonably effective in our hands and others.
Yeah, same experiences. Well, this was awesome. Great chatting with you guys.
Thank you.
Thank you.
Always.
Thank you.